Hello everyone, this is Nayiri from Low Carbon Fasting. So my guest today is, well, I have a returning guest. I've interviewed him before. The link to the interview will be below, check it out. So he is an author of several diabetes books. He's an endocrinologist. In fact, he is world-renowned expert in diabetes. Dr. David Cavan from Britain. Welcome to Low Carbon Fasting.
Thank you very much for inviting me again. It's a great pleasure to speak to you.
Dr. Cavan, last time I had you on, we talked about low carb and fasting, which is the name of this channel. So we talked about those two interventions to help diabetics, type 1 and type 2, manage their blood sugars better. Today, I would like us to focus on your most recent book. You do have a copy with you, right? So feel free to hold it up. So, the title of that book is How to Reverse Type 2 Diabetes and Prediabetes. So we're focusing on that book. However, for anyone who's not familiar with you, well, I already introduced you as world-renowned expert in diabetes. Could you possibly give a short sort of introduction of your background?
Well, I certainly can, and thank you for the kind introduction. I'm an endocrinologist specializing in diabetes, so I trained in a very traditional way, and my practice was very traditional in terms of managing diabetes for many years, based here in the UK on the South Coast. But around about 15 years ago, particularly when the information started to come out about the fact that type 2 diabetes could be reversed or put into remission, I challenged my own practice, if you like, and I explored lifestyle interventions in a way that I never had previously. And my focus in relation to type 2 diabetes since then has been to try and support patients as much as possible to use lifestyle as the way they manage their diabetes. And if they want to try and achieve remission, to support them in doing that, rather than treating it as we used to, as an inevitably progressive condition that just required more and more medication. And then along the line, I started writing books. My first book was published almost exactly 10 years ago in 2014, called Reverse Your Diabetes. And that described my early thoughts about how we can help people reverse type 2 diabetes. At that time, it was quite a controversial thing to say. Wasn't accepted by many people, particularly medical doctors, even though the evidence was there. I think since then there's been a massive greater acceptance. It's something that everyone now is very much aware of, and there are lots and lots more books around there talking about it. So this most recent book that you've mentioned is very much trying to bring all of that up to date. As you say, it came out at the beginning of this year, and is hopefully giving people the most up-to-date information.
Dr. Cavan's website link will be below. You can purchase the book through his website, but you can also purchase it from Amazon. So all the links will be below. Please get a copy of the book. Okay, Dr. Cavan, when you were talking, you used the word remission for type 2 diabetes. But in the title of your book, you use the word reversal.
Yes.
Are they interchangeable? Are they one and the same thing?
I'll explain how I use them, and I use the word reverse very, very deliberately, because I think it explains to people very clearly that the disease can be reversed, that the process can be reversed, and whereas remission is, to my mind, it's something that maybe isn't quite as clear to some people as to what actually does it mean. And but I'll explain how I use them. So we know from the pioneering work, I think, of Professor Roy Taylor in Newcastle in the north of England, we've known for around 15 years that the disease process that leads to type 2 diabetes can be reversed. And he showed that by using a very low calorie diet. Okay. But he showed the disease process can be reversed. And this again was I would reiterate, it was groundbreaking. Before, we'd always understood and assumed that over time, the process just gets worse and worse and worse. So I think I just want everyone to understand that that process can be reversed. Now, the term remission came in subsequently and is, if you like, a definition of if you have fully reversed your diabetes to the extent that your glucose levels, your blood sugar levels are completely normal, even when you take in a lot of sugar, okay, so your body can handle sugar again normally. If you have reversed your diabetes to the point that your overall glucose control or sugar control as measured by a blood test called HbA1c, if that is below a certain point and kept below that certain point over a period of time without medication, that is the definition of remission. And very specifically, if you can keep your HbA1c below 6.5% without having not been on any medications for at least 3 months and keep it there, that is the definition of remission. In the UK and other countries, we use different units, but the equivalent would be a level of 48 millimoles. So the remission, if you like, is the end of the journey, but the reversal is the journey by which you get there. And in order to achieve remission, then you have to have achieved reversal of the metabolic abnormalities, of the pathological abnormalities as well, things like accumulation of visceral fat in the liver and the other internal organs that lead to type 2 diabetes. So reversal is a process that you can achieve by lifestyle change, which can get to remission. But even, and I will emphasize this to people and do so in the book, even if you can reverse the process so that your blood sugar levels have come much down, you've been able to lose weight, you've come off medication, but your HbA1c is still a bit high, or you are still on some medication, you haven't achieved remission, but you've still improved your health hugely by that partial reversal of that disease process.
So, okay, so whether we call it remission or reversal, is that just the end goal? Because is that the end of one's effort, for example? Because you did mention that, you know, when people introduce glucose again, and if they can handle it, then what if they can't handle it? So
yeah, so I think it's fair to say that if you achieve remission, some people will be able to and again, this has been shown in a number of studies, you know, the pancreas can really recover, it can produce enough insulin to cope with almost whatever you're eating. But if you go back to eating foods with a lot of sugar or a lot of carbohydrates that will be constantly then putting your system under strain, then you will get, you know, one thing that I also say is remission is reversible. You know, you will then develop type 2 diabetes again. So it's not a permanent cure, regardless of what you do. But if you achieve remission and maintain a healthy body weight, maintaining an appropriate lifestyle and diet, then you can keep yourself in remission.
fascinating. Okay, so what is the disease process?
So the disease process
that leads to type 2 diabetes.
Yeah, so essentially there is a cascade of things that happen. And I guess the starting point is the fact that for many of us, and it's not just in the Western world now, it's in countries all around the world, we are eating the wrong things and too much of the wrong things. We're eating a lot of foods with sugar, with refined carbohydrates in them. And what happens is if we eat those types of foods, then the body naturally needs to produce a lot of insulin in order to stop the in order to avoid the glucose level in the blood getting too high. So to control it at a normal level, insulin is produced by the pancreas to take all of that sugar that's been taken in as part of an unhealthy diet and to get it out of the bloodstream. But it's got to put it somewhere. So what it does is it stores it essentially as types of fat in the internal organs, particularly in the liver. And that's one of the things the liver has been designed for. And if we go back into our to our ancestors many years ago, where food would have been scarce at certain times, then when food is plentiful, you store that excess energy as fat in your liver, and then when there's less food around, you can use that energy up. I don't know why, but it's just come into my mind as the concept of a bear that hibernates over winter. In the autumn, before it hibernates, it will eat. It will feed itself up, so build up fat stores that it can then use as its fuel to keep its body going over winter. That's a sort of an extreme version of it. The trouble is now we have no periods in many societies where food is scarce. So we have ready access to a lot of very high calorie, very highly refined processed foods that as we take them in, we're constantly driving our bodies to produce more insulin to store this energy away in the liver. The problem is, if we're not then having lean times where food isn't available and using that energy up, then the liver just becomes more and more filled up with that excess energy stored as fat. And what then happens, and this is where it gets a little bit complicated, but what then happens is a liver that is stored full of fat then begins to leak some of its glucose stores out from the liver into the bloodstream. Okay. And so the blood sugar level, the blood glucose level stays up or goes up. And then the body has to produce even more insulin to try and keep those glucose levels down, to push that back into the liver as fat stores. But then that again leads to this leaking of glucose stores out of the liver into the bloodstream. So you get this vicious cycle where the system is being fed excess, essentially sugar, because that's what it is to the body, that it has to be converted and stored in energy into the liver, which then paradoxically leads to sugar leaking out of the liver, causing the system causing the levels to rise. And then over a period of time, often years of this process happening, you get to a stage where the body can no longer keep that glucose level within normal limits. And if the glucose level goes above a certain level, it is by definition called prediabetes. And then if it goes higher, it is type 2 diabetes. And as I said, that can take a number of years to happen. So that is the disease process. The reversal of the disease process essentially means trying to rid your body, try and use up those excess fat stores in the liver. Because if you can do that, then the other aspects of the liver function begin to normalize. Glucose levels begin to come down. As glucose levels come down, the pancreas doesn't produce so much insulin. And so it turns that vicious circle into a virtuous circle. And if you keep your levels down, as I said, then you can reverse that process and achieve remission.
So so achieving remission or reversal does involve getting rid of the liver fat.
Absolutely, yeah.
So I loved your bear analogy. So clearly we are never hibernating. We're never really giving our livers a break. We're constantly feeding ourselves. So that is the main problem. So what other organs get damaged by excess fat? How about the pancreas?
So as part of this process also, there is deposition or storage of excess fat in the pancreas as well. And what has been shown is that as the pancreas becomes infiltrated with more fat, its function is also impacted, and so it directly then affects the ability of the pancreas to produce insulin, which is one of its key functions. And it's very interesting the very clever studies and metabolic studies and measurements that have been done by Professor Roy Taylor and his colleagues have shown that you only need to lose about 1 gram of fat from the pancreas and to have a significant impact in improving the way it works. So the pancreas appears to be very, very sensitive to just small amounts of fat accumulating in there can have a big impact on the way it works.
So what would you answer to people who've been diagnosed with type 2 diabetes and they're all confused, they don't understand the process? And in fact, I've had this question in one of my groups. People say, is my pancreas broken? It's not working anymore.
Right. So it might not be broken, but it's been injured, if you like. You know, it's struggling, and you know, this might be a good point just to highlight the difference between type 2 diabetes and type 1 diabetes. Type 1 diabetes is a condition where, if you like, the pancreas is broken, or the cells in the pancreas that produce insulin no longer produce insulin, generally as a result of an immune attack by the body's immune system. And so in type 1 diabetes, the problem is you do not have enough insulin in your system, and that's why your blood glucose levels rise too high. In type 2 diabetes, it's more the fact that you have what is called insulin resistance. So I mentioned that the disease process is a result of the body taking in too much energy in the form of sugar and refined carbohydrates, that causing the pancreas to produce or needing to produce a lot of insulin in order to manage that. And then because of that vicious circle, despite producing a lot of insulin, the sugar levels are still high, so you need to produce more and more insulin. But it's not working. It can't control the blood sugar levels. So that, by definition, is insulin resistance. And that's what the problem is in type 2 diabetes, alongside, as I said, once you have that fat infiltration in the pancreas, it can no longer produce insulin, enough insulin in order to control the glucose levels. So the pancreas, if you like, it's not working properly. It's been injured, if you like, as a result of this excess fat. But the great news, as you know, we've been emphasizing, is that by lifestyle change, it is possible to if you like, heal the pancreas, or to mend it to an extent that it works better, even if it is not working perfectly for the future.
Injured, but it can heal. Yep. Right? It's the kind of injury that, one can heal through lifestyle change. Right. Okay. So you mentioned the excess glucose from the liver.
Yeah.
Flowing back into the bloodstream. Where are the triglycerides coming from? Because a lot of pre-diabetic people or even diabetic seem to have high triglycerides. So let's talk about that process too, please.
Well, this is part of the process where the body takes that excess glucose and then it stores it. Triglycerides are a type of fat, but it is then stored in the liver, if you like, as triglycerides derived from the glucose that has been taken from the bloodstream. But that then can absolutely lead to the level of triglycerides in the circulation in the bloodstream being quite high. And as you absolutely say, it's one of the first signs of the metabolic abnormalities associated with this disease process. It's a very good sign of insulin resistance. Is if the triglycerides are too high, it's a good marker that all is not well. But again, they will come down as you reverse the process. The triglycerides generally will come right down to a very healthy level.
I think we now have to mention the diagnosis criteria. So what do you look for when you're diagnosing someone with prediabetes? I mean, for diabetes, it's very easy. You just Google search. It may be slightly different in different countries, but type 2 diagnosis criteria is very easy. Okay, HbA1c is at that point, so you're type 2 diabetic. But how do you diagnose someone with prediabetes?
So these are arbitrary definitions, okay? And with type 2 diabetes, if your HbA1c goes above 6.5% or 48 millimoles, you have type 2 diabetes. At that level, you are very unlikely to have any of the typical symptoms associated with diabetes. So yes, if your glucose levels are very high, you'll experience thirst, you might lose some weight, you might have blurred vision, excess urination, all signs of high glucose levels. You do not get those symptoms at an HbA1c of 6.5 or 48. So the diagnosis is almost always done by a blood test, which gives that gives that level. Now, so that's for type 2 diabetes. Pre-diabetes, and this is where it gets a bit complicated, because the American Diabetes Association and some record or defines pre-diabetes as someone where their HbA1c is above 5.7%. Okay, so if it's below that, you're normal, but if it's above 5.7, you're defined as having pre-diabetes. In the UK, much of Europe, and the World Health Organization definition is a bit higher. That's at 6%. So here, if you have an HbA1c of 5.9% or 41, it would be, then that is regarded as normal. But in the US, that would be regarded as pre-diabetes. So it does get a bit complicated. But everyone is agreed, if your HbA1c is between 6 and 6.5, that is pre-diabetes. The other unit equivalents are between 42 and 48. That's the bound of pre-diabetes. And again, you are unlikely to have any symptoms at all, because your blood sugar levels are nowhere near high enough to cause the symptoms. So it is done on the basis of a blood test, or diagnosed on the basis of a blood test.
Blood test, basically just looking for HbA1c.
Measuring the HbA1c, usually, yes. It can also be done as on a fasting glucose level, but nowadays the HbA1c is generally what is used to make the diagnosis.
Right. So would it be correct to say that with or most people with prediabetes or type 2 diabetes, but prediabetes also have hyperinsulinemia?
Yes. Yeah.
So if that's correct,
yeah.
Do you in your clinic measure insulin levels?
Very good question. So yes, by definition, just to go back to that disease process, that the point throughout that process, insulin levels are getting higher and higher, because the body's resistant to it. So more and more insulin is produced. That is what is hyperinsulinemia. And by the time the blood glucose levels are right, have increased to make the diagnosis, insulin levels could have been high for really quite a long time. So it leads to a very obvious and very sensible question: do we measure insulin levels? Well, the answer is quite complicated. The simple answer is no. In the UK, the National Health Service does not provide measurement of insulin on a routine basis, and there are a number of reasons for that. it's not just cost, it's the processing, and it's not a very, very easy thing to measure, or hasn't been historically. I think things are getting easier, so it is not readily available. If you go to a private clinic or a private lab, then yes, you can get it measured. So it's that sort of situation where, yes, if you pay for it, you can get it measured, but it's not routinely available or reimbursed via the UK health system. And that's different in different countries. But it really would make sense to measure it. Is, I guess, an obvious thing to say, but then it gets then it can get a bit more complicated, because insulin levels vary, just like glucose levels, quite a lot. So if you're fasting, they'll be different than if you've just eaten, and so on and so forth. So interpreting it isn't always very easy. And actually, what most people will say is, and I mentioned just a little bit earlier, triglycerides, for example. The ratio between HDL, which is a type of cholesterol, and triglycerides, or even total cholesterol and HDL, and things like waist circumference. There are very easy things that we can measure that have been shown to correlate very closely with insulin resistance and therefore hyperinsulinemia. So do I think it's a problem that we can't routinely measure it? In most people, no, it's not, because we can infer it from those other things, and because we know we have interventions which if they then improve those other markers, like the triglycerides, like reducing waist circumference, then we can be, in most cases, really quite confident that the insulin resistance and the hyperinsulinemia is improving, even though we can't always measure it directly.
So what ratios do you look for? Triglyceride to HDL ratio for insulin resistance? Or is it the total cholesterol?
Sorry?
Or do you look for the total cholesterol? I think that's the routine one on NHS, total cholesterol divided by something else.
So the routine one is total cholesterol divided by HDL, but triglycerides, HDL and triglycerides, you can use a number of different markers, and often they'll track together. But the general lipid panel that is done nowadays will measure total cholesterol, HDL, and triglycerides. So you can use whichever you choose. You can calculate them from those results.
So what are optimal numbers for your patients? Where do you want them to be with respect to their lipid panel, for example? Do you really pay much attention to the total cholesterol, or do you just focus on the HDL and the triglycerides?
I think that again, that's a really good question, because I get so many people asking me, they're concerned about their cholesterol levels because they're raised, and they've been advised they need treatment, or they've got to do something to get them down. So and I'm not sure if I should speak numbers, because it'll get really complicated, because the numbers used in the US are very, very different from the numbers used in the UK. But let me just try without numbers, and we can see if we can get there.
You can just put the conversions on the screen.
Yeah.
So
the total cholesterol level, by definition, it includes lots and lots of different subtypes of cholesterol, and there are two common ones. One is HDL, another is LDL, but even LDL, there are different subtypes of it. So it is still a huge oversimplification. And in the past, we've been taught that LDL is the bad cholesterol, and if your LDL is raised, then that is a bad sign. You're at risk of heart disease and so on and so forth. But we know that some LDL is not bad at all. So just using the LDL itself is problematic. On the other hand, if you have a high level of HDL, that is universally regarded as being a good thing, because HDL is seen as being a protective marker. You know, HDL cholesterol is a healthy type of cholesterol, and so if you've got a good high amount of HDL, that will automatically increase your total cholesterol. Because the total cholesterol adds up the amount of HDL and LDL and all the other bits. So you could have a high total cholesterol, which is above range, but it's above range because you've got actually a very high and healthy level of HDL cholesterol. So that's why the total cholesterol is not always helpful, can be problematic. Triglycerides will usually come down with an intervention that reverses the diabetes disease process. And so triglycerides, the lower the triglycerides, the better. And we don't have to worry about different types of triglycerides. Okay, the triglyceride number is the triglyceride number, and the lower the better. So of all those different numbers, the two that are most useful would be the triglycerides and the HDL. And the higher the HDL and the lower the triglycerides, the better. Okay, and so what I will often say to people, they may say, well, look, my total cholesterol is high, and I'm really worried about it. But and then we look and we say, well, look, your HDL is a really good level, and your triglycerides are very low, and your total cholesterol therefore is probably high because the HDL is making it high. So don't worry so much about it. I don't know if you're going to then go talk about or want to talk about the response in some people to a low carbohydrate diet, where their cholesterol levels can go off into really quite high levels, and the LDL particularly can go quite high
too. Let's please talk about that. Do you worry if when people start low carbohydrate diet and their waist circumference is getting better and their blood sugar's coming down, but then suddenly, and this doesn't happen in everyone, but suddenly their LDL starts rising. And of course, the total cholesterol will rise too if your LDL is risen.
Exactly. When often HDL will rise and LDL will rise and the total will rise, and it can rise to really quite high levels. And it's quite a complex phenomenon. It's the people in whom this occurs are called lean mass hyperresponders, which is a big mouthful, but they're generally people who are very lean, so they're not overweight, and their cholesterol levels can go really quite high. And but if you look at these people, as you say, their waist circumference is low, they're healthy, they're not overweight, their sugar levels are normal, and so, but they have this high cholesterol level. And the way that I guess I would try and simplify the explanation is that if you're on a very low carbohydrate diet, which is when this generally happens, you become what is called fat adapted. So your body is preferentially burning fat as its fuel rather than cholesterol. At a very simple level, that means there's a lot of fats that is being transported around around the body to be used as fuel in different tissues. And LDL cholesterol is essentially cholesterol that is being transferred. It's the transporter of cholesterol around the body in the bloodstream. So at one level, it's just telling us that the body is fat adapted and there's a lot of cholesterol whizzing around in the bloodstream. Now, that's a very simplistic sort of explanation, but I think it can help explain why it might happen in people who are fat adapted. Now, what's interesting is that most of that LDL will appear to be actually, and remember I said not all LDL is bad, most of that LDL will be the better type of LDL anyway. So it's not such a big issue. But if it is something that is concerned about, what studies have shown is if you do increase your carbohydrate intake a bit, then that cholesterol level will come down. So you're not relying quite so much on fat for your fuel, and it can be manipulated. But other people are quite content. They feel healthy, they're metabolically healthy, their cholesterol is high. If people are concerned, they can get scans done of their heart to see if there's any sign of any disease in their arteries, and if that comes back giving them a very good score, then you can be reassured. And what that is telling you is just that there's a lot of fat flowing around your body to feed your, to fuel up your different organs.
Dr. Cavan, is the detailed lipid panel test where they look for LDL sizes or LDL sort of density or patterns? I think pattern is the word that they're using now. So is that test available in the UK?
It's not part of the standard lipid panel. The standard will just give you the total LDL, but there are labs where you can get the different subtypes, and you have particle size and buoyancy. The sort of large buoyant LDL is what you want to look for, rather than the small dense LDL. So yes, these things can be measured, but generally not via the standard lipid panel, and generally in the UK you would need to pay to have those done.
It's the same here in the US too. So
okay.
I know that they're not routinely covered,
Yeah.
but you can pay out of pocket for those things.
And I think, if I could just say, I think in most people, just like measuring insulin isn't always necessary, doing these measurements isn't always necessary. If you're the sort of person where you need to know your numbers, you need to know exactly what's going on in your body, and if you don't know them, you'll be anxious, then yes, you may choose to invest in getting those done. But if you can see that your health is improving, that the numbers that matter are improving, and you can be reassured for the explanation as to why the LDL might be high in your particular case, then we can, that should, for many people, that will be sufficient.
Dr. Cavan, you mentioned the low carbohydrate diet earlier on as an intervention, which is what you do use in your clinic. So how do you define low carbohydrate diet? What's your definition of it?
That's a really good question. Well, the standard definition of a low carbohydrate diet is a diet where people are eating less than 130 grams of carbohydrate a day. That's just a definition. To put that into context, in most Western societies, the average carbohydrate intake is between 250 and 300 grams a day. So 130 is about half, or less than half, of what most people are eating. Okay. What I generally say to people, though, is so I don't say, well, you've got to eat a certain amount of carbohydrate or reduce to a certain amount of carbohydrates, but I would explain the definitions. Okay, so 130 is the definition. So that's coming from the top end. So we're coming from the average of 250 to 300. A low carb diet starts at 130. From the other end, we have interventions that will, like the carnivore diet, have a very, very low carbohydrate intake, or a ketogenic diet, which is generally below 20 grams of carbohydrate a day. And with what we're trying to do with a low carbohydrate diet is, certainly what I would say to people is think qualitatively, not quantitatively. By that I mean, don't count out up your carbs and try and restrict to a certain amount unless you particularly want to. But start by looking at what it is you're eating. And there are two things that I suggest. Number one is to try and cut out sugar in all its forms as much as you possibly can. Because that, for many, many people who are on 250, 300 grams of carbs a day, a lot of that is sugar in all sorts of foods. And if you just cut out sugar in some people, that will halve their total carbohydrate intake. And that alone could have a massively beneficial effect in reducing their glucose levels, enabling them to come off some medication potentially. And I can think of one young man who his diet was pretty much sugar, soda, sugar sweetened beverages. He had type 2 diabetes, and he was just drinking sugar all the time. And as I was able to encourage him to stop that, he was able to come off insulin, which he was being treated for, which was his treatment for his type 2 diabetes. So absolutely, number one is to try and cut out sugar as much as you can. And then I say, try and avoid large portions of starchy foods. So things like the bread, rice, pasta, potatoes, breakfast cereals. And if some people want to interpret that and say, well, I want to cut them out completely, that's fine. But if other people want to still enjoy a little bit of starchy food as a small part of the meal, but what I say very deliberately is try and avoid the large portions. So the large portions of rice with a curry or with a Chinese meal, the large portions of pasta, the large pizzas. Try and avoid those. And then, and it's all explained in the book really, is what I really want people to do is to define their own diet, their own definition of a diet that works for them. And for some people, it will be a carnivore diet or a very low carbohydrate ketogenic diet. Dr. David Unwin, who's a GP in the UK who has a large series of patients who've put their diabetes into remission, I think he found that the average carbohydrate intake in those patients was around 70 grams a day, 70 to 75 grams a day, which is well below the 130, but certainly not at the very, very restrictive level. So it will enable people to enjoy some starchy foods as part of the meals if they want to. But by looking at it qualitatively, measuring the response by measuring your blood sugar levels to what the changes to your meals, how that's helping your blood sugar levels, people can then find their own level. And the reason why I encourage people to find their own eating pattern that works for them is this has got to be sustainable really for forever. We're not talking about a short-term intervention, a 3-month intervention or a 6-month diet. We're talking about retraining your eating habits permanently. And so it's got to be sustainable. And if you're finding that you're on 20 grams of carbohydrates a day, you're never eating bread, you're never eating rice or pasta or potatoes, but you're feeling as though you're denying yourself, that won't necessarily be very sustainable. And so just finding the pattern that works for you, I think is what I advocate, what I suggest, rather than saying to someone, right, you've got to get down to 30 grams a day. But that will suit some people. Some people will want to do that. I'll just as an anecdote talk about a lady who is quite active in this field, and she's told me, she follows a ketogenic diet, a very low carbohydrate diet, but she has 3 favorite very high carbohydrate meals, and once a year she'll have each of those. And she'll know that her sugar levels will go up and all the rest, but she'll enjoy it. But the rest of the time, keep to a very, very low carbohydrate diet. So really, just to summarize, the key factors are cutting out sugar as much as you can, avoiding large portions of carbohydrates, and then you learn how your body responds as you do that, and then you work out what is the eating pattern that helps you achieve the goals that you want. Because again, I'm not interested in telling someone, well, you've got to put your diabetes into remission, you've got to do it like this. What I want people to do is you identify what your own goals are, and that might be to lose a certain amount of weight, it might be to come off some of your medication, it might be to achieve remission, but then you work out, with the help of resources and advice that you can get, you work out how you can best achieve that within the framework of overall reducing your carbohydrates.
So what you're saying is that individual context
Yes.
matters because people respond differently to carbohydrates. I guess they have different. I think Craig and Maria Emmerich in the keto space, they call it the threshold. So your glucose threshold, right? So in summary, people can achieve remission at different levels of carbohydrate consumption.
I think absolutely so. And again, Dr. Unwin, and I know you've spoken to him as well in the past. He also has a large group of patients with pre-diabetes, and something like 96% of those were able to achieve remission from pre-diabetes to normal by going onto a low carbohydrate diet. And the if you remember the definitions, that pre-diabetes glucose levels are only a little bit higher than normal. So you can see you don't need to make huge changes to bring them down a small amount. Whereas if your HbA1c is 12% or 100, 120, you're going to need to make a lot of changes to get it down. So everyone is different depending on where they are in that pathway, in that process, from just being pre-diabetic to having type 2 diabetes with very high glucose levels, or somewhere in between.
Dr. Cavan, I'm interested in this CGMs. I mean, they're available they're readily available in the UK. Maybe not prescribed to all diabetics, but they are mostly prescribed to type 1 diabetics. But do any of your type 2, because we're discussing type 2 today mainly,
Yes.
do any of your type 2 diabetic patients use
Yes.
CGMs?
And I encourage people, that's not reimbursed on the NHS, but I encourage people to consider using it, so purchasing it themselves, even if they're going to do it just for a few months while they go through this process. And I recommend in the book that if you as you begin this process of changing your diet, working out what works for you, the absolute best way to do it is to wear a CGM, because then you can see exactly what happens to your blood glucose when you eat, every time you eat. And you may find, and what's very interesting, looking at different types of carbohydrates, I mean, some people will say, oh, I can eat a meal with a few small potatoes and it has no effect. But if I have that equivalent amount as rice, it pushes my levels very high. So again, everyone is different. And so if you can learn from what your own body does with certain meals or certain types of food, then you can again very much personalize your dietary plan according to basically what your body can handle. So I definitely recommend a CGM, maybe for 3 months while you're making those changes. And if by doing that you can achieve remission or achieve your goals in terms of glucose levels, absolutely fantastic. And if it's feasible for you to continue using a CGM full time, do so. Otherwise, every 3 months or so, wear one for 10 days, 14 days, just to make sure that you're staying on track. But yeah, I absolutely recommend it. I wish it could be available to everyone with any type of diabetes. We're not there yet. I'm sure we will get there at some point.
But the prices are coming down, I think. So, and they're more readily available now. So, all right. So for type 2 diabetics or even pre-diabetics who are wearing a CGM, I'm really curious to know this. What target do you set for them, or what target range do you set for them, or does it differ from person to person?
So, and I know there's a lot of controversy around this. By definition, by a consensus definition, and we might not agree with it, the target range is between, well, in the UK units, 3.9 and 10 millimoles, which is 70 and 180 milligrams. And some people feel that that's much too wide, and actually it should be about, the top the top shouldn't be as high as it is. It should be much lower. I don't actually necessarily agree with that, because even in people who don't have diabetes, their glucose will, even if it's only for a short period of time, will go up to that sort of level and then come straight back down again. So this idea that you have to have a completely flat line the whole time, I don't ascribe to that necessarily. So I'm comfortable with that being the target range. But we also need to look at what the average glucose is. And you could have an average glucose of 9, and it being 9 all the way. But because you're within range, you've got 100% time in range. Well, that's not good. Okay, so we've got to be sensible about it. So yes, we have that range, but we then need to look at what the average glucose is, and that generally needs to be as low as possible within that range. And some people who have type 2 diabetes, but it's managed well on diet alone, their average glucose will be somewhere between 6 and 7 millimoles, which would be about 120 to 140 milligrams. And as you know, the CGMs will also estimate an HbA1c on the basis of that, which is a bit like reverse engineering, because the whole point of the HbA1c was to give an indication of glucose levels. So I don't want to get into that too much. But you know, if you can achieve average glucose levels that are in the lower end of the normal range, you're a very high percentage of time within range. And I'd be looking for someone, obviously by definition, someone who's trying to achieve remission. They should be nearing 100% time in the target range. But rather than absolute numbers, and you know, you said what do I sort of say to people? What should they be achieving? The point of using the CGM really is to help people see how they can improve. So if they put one on first of all, and they're on their usual diet, their average glucose could be well above the target range. Their time in range could be something like 10%. And what you're looking for is just to see how that improves over time as they make their lifestyle changes. Yeah, again, you'll have gathered, you know, I don't really like a prescriptive approach. I would like people to use the tool for them to help achieve the goals that they want to achieve. And if your goal is to get an average glucose of 100 or 5.5, then that's your goal. That's what you need to strive for. But that comes, for me, I want the individual to decide that for themselves rather than me telling them that's what they've got to do.
Dr. Cavan, do you look for, or do you pay much attention to postprandial rises? So
yes, yeah.
And so what's normal rise after a meal, and what's the duration? What's a healthy duration for that rise?
Yeah.
For type 2 diabetic, obviously, before it comes back down again, because they're not taking insulin. So I don't want to bring in the type 1 in here. So for a type 2 diabetic, the body should take care of it.
So what you're seeing, very often when you look at a CGM with anyone with diabetes, what is very clear is very often when they're not eating, their levels are nice and stable. And just by looking at their CGM, you can see when they've eaten, because the levels go up and then they come down again. Now, by definition, we've talked about definitions and diagnostic criteria for diabetes using HbA1c. We used to use something called the glucose tolerance test. Yes. And the glucose tolerance test measured the blood glucose before you had you took in some glucose. You then have a drink with 75 grams of glucose, and then it measured 2 hours later. And it measured 2 hours later because by then your glucose should have come down. But recognizing in the meantime, even in someone without diabetes, it may go up. may go up to 150 or 9 millimoles for, I don't know, 15 minutes. But by 40 minutes, it's come down, and by 2 hours, it's completely back to where it should be. So I say that just to emphasize again that in a person without diabetes, it does not stay a flat line. Okay, so it is completely normal if you're ingesting carbohydrates that there will be a postprandial increase. The issue is how high is that increase and how long does it go on for? So by definition, we want it to be as low as possible and as short as possible.
Yeah.
Okay. And there are certain things, if you eat a big bowl of pasta, for example, even if you have type 1 diabetes and you're injecting insulin, that pasta can cause a rise that goes for many hours because of the nature, one, the load of the carbohydrate, but also the nature of it is broken down quite slowly. And that's clearly not healthy, because we know these postprandial levels contribute to some of the problems that we see with high glucose levels. So yes, it is okay to have a rise after meals, but again, and I'm not going to put numbers on it, you want it to be as low as possible and as short as possible. And where you need to be particularly concerned is if it's going above I don't know, a level of 9 or say 150, and particularly if it's staying there for more than an hour, then that's too much.
Right. Let's talk about hypoglycemia. So for type 1s, obviously, the CGM is useful for a type 1 because it will alarm you and alert you to go take your glucose tab or whatever you want to drink at that point. How does the body of a type 2 diabetic take care of hypoglycemic sort of events? So because we see that in non-diabetics, when they wear a CGM, and they experience sort of levels below 4 or below 70 in American measurements. So what happens? How is their body taking care of it?
Okay, so we need to understand that there's a slight difference between definition of hypoglycemia for someone with diabetes on insulin and what is genuine hypoglycemia. So a level below 4 or below 70 is regarded as hypoglycemia for someone on insulin, because you want there to be we have in the UK a phrase, 4 is the floor. We don't want it to go any lower, because then there's a risk of it going into true hypoglycemic levels. For someone who doesn't have diabetes and who has been fasting, you may well go below 4. You may go down to 3.5, so from 70 to 60, something like that, and that can be completely normal. It's not abnormally low. And if you have type 2 diabetes or pre-diabetes, you will not go, your glucose level will not go abnormally low to a dangerously hypoglycemic level. The only things that cause that are insulin or some medications called sulfonylureas that increase the insulin in the body. No other type of medication, diabetes medication, will cause dangerously low hypoglycemia. So yes, you may wear the CGM and see that it dips below 4 and it might go down to 3.5, but it is not the danger or the risk that it is in someone who is on insulin treatment, particularly with type 1 diabetes. So usually you can reassure people the point of the CGM is not to stop it going low, it's to make sure that it's not going too high.
Or minimizing the fluctuations on a daily basis, the highs and the lows.
Yeah.
And that's what I focus on as a type 1 too.
Sorry, I was talking in type 2.
Now we're talking type 2, but even for type 2 diabetic, I think minimizing those fluctuations
exactly, yes,
would be a wise thing to do, a strategy, I think. Okay, let's talk about ketones. Do you measure ketones, or do you give them any device to measure their ketones? Is it of any type 2
No, I
diabetes?
don't. I don't. And interestingly, I guess you're talking about people on a ketogenic diet for ketone measurement in type 2 diabetes. And interestingly, quite a few people who use a ketogenic diet don't routinely measure their ketones. They're just happy to, accept that they're getting the goals, they're achieving the goals they want. They're getting, what they want by the dietary change that they're choosing. But for some people, staying in ketosis is important. It's an important part of their lifestyle as to how they want to manage their diabetes. And in order to do that, you need to measure ketones. And so in that situation, yes, people will access a meter in order to measure ketones. But I never say to someone who wants to reverse their diabetes or put it into remission that you need to measure your ketones.
So there is no risk of ketoacidosis, for example, with a type 2 diabetics, even when their pancreas is compromised?
So I was talking about measuring ketones to establish ketosis as part of your dietary intervention. As you know, everyone with everyone who is insulin deficient, as in type 1 diabetes, is at risk of ketoacidosis and therefore needs to be able to measure their ketones if they are feeling unwell and their glucose levels are raised. There is a very small proportion of people with type 2 diabetes who, if you like, behave like type 1 diabetes and are insulin deficient, where, yes, they're essentially managed as if they have type 1 diabetes. And so that same advice is pertinent. But to the vast majority of people with type 2 diabetes, ketoacidosis is a very low risk. It's just, in the absence of insulin deficiency, it's not going to happen. So if you have type 2 diabetes and you're hyperinsulinemic and you're managed with metformin and another medication, a GLP-1, for example, your risk of ketoacidosis is very, very low. There is a slight caveat to that, because there is one type of medication called an SGLT2 inhibitor, which in the context of people who are insulin deficient is associated with an increased risk of ketoacidosis. Now, if you've identified those people, ideally they shouldn't be on those medications. So it should be stopped. But if for some reason you have someone at high risk of ketoacidosis on an SGLT2 and you want them to stay on it, then they need absolutely to be able to measure their ketones and know the risks. But generally, that is not a clinically viable thing in most settings, because it's not recommended that those sort of people should be on those medications.
It's been wonderful chatting with you. We've got to arrange a third episode, I think. There's so much more to talk about. And hopefully next time we'll discuss just type 1 diabetes. This was so educational and informative. Thank you so much, Dr. Cavan, for your time.
Not at all. Thank you again for having me.